Alrighty, so here we go with the Geriatric Giants. We're going to cover a number of these things as well over the course of the semester, but I did want to give you a basic background in regards to a number of the major issues that are felt to be important in geriatrics. These are the 5 or 6 major issues that seem to define geriatricians versus other providers. When I first started doing geriatrics years ago, they referred to them as the 5 I's of geriatrics. There's been some subtle changes since then. I still use the original, but there's some moderation of that. The thing with that is that those I's seem to evolve a little bit over time, but basically the same issues continue to be important. So for cognition, the key issue here is to make sure that you do the differential diagnosis of delirium versus dementia. Delirium, by definition, is an acute reversible confusion. Dementia is a chronic, non-reversible confusion. And so, obviously, if something's reversible, you want to do the appropriate evaluation and fix it. Unfortunately, a lot of times when people see someone that are confused, they assume they're demented and don't do the appropriate evaluation. So again, you just need to make sure to do that evaluation. We used to talk a lot about pseudo-dementia, which is a depression which presents as dementia. We're less sure that that exists now. We really feel like probably the majority of those folks will progress to dementia. But as you can imagine, on a Folstein, if you ask somebody what county are you from and they say, I don't know, it could just be the apathy of depression as opposed to a true dementia. So be careful to make sure that you do an evaluation. The other thing, of course, is that the elderly can often present with depression without sadness. So again, keep that in mind for your differential. When you're doing your differential, make sure to carefully rule out delirium. We'll talk in a minute about the laboratory panel that you want to do and the assessment that you want to do. Once you've ruled out delirium, then you need to look at the diagnostic criteria for dementia. And in that diagnostic criteria, you'll see that there needs to be a progressive decline in 2 or more cognitive domains. Memory is very common, but attention, perception, and motor skills, language, visuospatial abilities, problem solving, and executive functions also can be impaired. There's a lot of interest in minimal cognitive impairment, minimal memory impairment of aging, whatever you'd like to call it. In fact, those folks just have very mild issues. As we age, it does seem like some of those cognitive functions do slow down a little bit, but they won't slow down enough to really cause functional issues, as well as they don't really have a progressive decline. The language issue that sometimes comes up is word finding, but it usually is a mild issue. They never lose the ability to understand those words, and it is very common as a person ages for them not to be able to think of a particular word. But again, that's a mild cognitive impairment or minimal memory impairment of aging as opposed to a true sign of a dementia. When you're doing a cognitive assessment, a number of different options exist. You can do the Folstein Mini Mental Status Exam. The Folstein is actually a proprietary test, however, so technically you're supposed to pay a small fee every time you do it. Almost no one does that, but technically you are supposed to do it. A lot of us will use the Mini-Cog instead. The Mini-Cog is a 3-item registration. I always use Apple, Table, and Penny, and then 2 or 3 minutes later you ask them to recall those words, and so they get three points for the registration, 3 points for the recall, and then for the clock drawing, you basically ask them to draw a clock with the hands at 10 minutes past 10, and if they come somewhere near that, they're probably going to be okay. On the other hand, if it is abnormal, you do need to progress to do additional other testing to determine whether they might have some kind of confusion, such as delirium or dementia. The clocks test is a little bit more complicated. I'll let you look that one up. But basically it's another drawing a clock test, and it has a number of different points for it. For physical exam, you're going to focus on the neurologic exam, see if there's any lateralizing of motor or sensory deficits, see if there's any balance issues, see if there's any changes in the neurologic exam. You're going to look for other things, of course, heart exam, making sure they don't have AFib that would make them at greater risk of stroke, generally looking for overall physical issues, but it's uncommon that they have those, and you just want to do the physical exam to rule those out. Laboratory testings, the usual delirium panel is a CBC, chem profile, TSH. TSH probably by itself is enough. Some folks do add the free T4, but the TSH is probably enough for screening. The T4 itself should probably not be done, but if you're going to do the T4, make sure it's the free T4. It seems to be more sensitive and specific to thyroid issues. SED rate gives you an idea of whether there's any inflammatory or infectious process going on. Serologic test for syphilis, whether it be the VDRL or the RPR, whatever your facility does. HIV if indicated. Personally, I only do this if there's some sort of risk factor or some sort of concern, but you're going to probably be seeing more HIV patients with HIV dementia over time. Lyme testing, probably as a routine. Some do stratify as far as risk, but it's something that you can, try to decide and then go ahead and decide whether or not to order that test. B12, whether we need to do that on top of the CBC is a good question. If the CBC shows macrocytosis, of course you want to do it. There are people that will have a bit of a B12 deficiency even with normocytic cells, especially if they have, both an iron deficiency and a B12 deficiency. Those two will average out. The RDW in that case, however, would usually be high. If the B12 is in the lower ranges of normal, some folks will add a methylmalonic acid just to make sure that there's not a B12 metabolism issue, but it is something that is really kind of dealer's choice. Tox screen is a really good thing to do to check for any sort of drug exposures. Cardiogram is a good idea, as well as probably imaging their head in some way. Whether it be a CT or an MI is an interesting question. A lot of folks will just do the CT to make sure there's not a space-occupying lesion. MRI is, of course, more sensitive, looking at the lower aspects of the brain, the cerebellum, the pons, the medulla, so that's really your call. So if someone has dementia, then you have to decide what kind of dementia they have. A lot of us have assumed up to this point that the majority of patients have Alzheimer's dementia. In fact, that may not exactly be true. Probably more than 50% have Alzheimer's dementia, but that's an interesting argument at a number of different levels. Frontotemporal dementia is becoming progressively more normal. Those folks present very differently, so you do want to understand what FTD is and know how to diagnose it. Vascular dementias are very common. Basically, these are mini strokes that are causing cognitive issues, and you need to be very aware of whether or not someone has some kind of a vascular dementia. Lewy body dementia is also a bit more common than it used to be, or at least we're more aware of it. Usually these are patients that are thought to have Parkinson's and Parkinson's dementia. However, if you put them on a Parkinson's medicine, they just don't seem to respond. Again, being aware. A lot of patients will have mixed dementias. Alzheimer's and vascular are the most common that will occur together, but any one of the dementias can occur together. So just to review on Alzheimer's, dementia, plaques and tangles occur, and it is probably at least 50 to 75% of the cases of dementia, but again, there's a lot of folks that probably don't have it. Time to death is usually about 10 years. It usually is a progressive dementia. If they don't progress over that time, you need to ask yourself if maybe they have a vascular dementia that looks more like an Alzheimer's dementia. There's several different A signs that occur: amnesia, of course, loss of memory, aphasia, difficulties with language. Note that I say language and not speech because it's basically the ability to express or understand as opposed to the ability to actually produce speech in the motor aspect of it. Agnosias are perceptual issues. Stereognosis, the ability to put something in someone's hand and have them identify it, often goes away. And apraxias are actually motor planning issues. So when a patient has an apraxia, they'll start to have difficulty with ADLs, with their motor functions. So patients with Alzheimer's disease often have mood swings, often can be aggressive, often have delusions, and when they are hospitalized, you need to be very careful not to use benzos. Benzodiazepines often will cause a long-term confusion with those folks. Lots of times that's exactly what people do. They give them a little bit of Ativan. The problem is that sometimes that can cause days of confusion. Interestingly, the older antipsychotic meds such as Haldol seem to have less of an issue. We used to call it vitamin H. So it is something to keep in mind if you're in a hospital situation and you're managing people with confusion. So frontotemporal dementia, we used to call this Pick's disease, usually has an earlier age of onset, often as early into the 40s or early 50s. Usually when someone gets this, if you ask them if other members of the family have had early onset confusion, there usually is a family history. One of the sort of hallmarks of FTD is that they usually have personality changes. They'll go from being very easygoing to, very hard to get along with. Their conduct will change. Sometimes it's hard to tell the difference between this and sort of a midlife crisis, although usually the kinds of behaviors are much more extreme with this. They may start to have changes in expressive language, naming, comprehension, and usually once it gets to that point, the diagnosis becomes a bit easier. Hard to treat this. There's not a lot of medicines or anything else that really help it. Can be a very challenging condition for clinicians and family. Vascular dementia, basically we used to call this multi-infarct dementia, and it's usually a case of multiple strokes that have happened to someone. The usual things that you would pay attention to: hypertension, hyperlipidemia, risk factors for stroke. You want to make sure that you control their blood pressure, control their lipids, and basically just kind of keep an eye on everything. Beyond that, there's not a whole lot you can do. Usually if you control those things, they'll stop having the strokes and they'll sort of stabilize. Again, they can go long periods of time without any increase in their symptoms, which is usually different than patients with Alzheimer's. Usually patients with Alzheimer's will progress. So the Lewy bodies, folks will have fewer tangles. If you actually do a brain biopsy or a postmortem, they will find these structures called Lewy bodies found throughout the cortex and the substantia nigra. Substantia nigra, of course, is the area that is affected in Parkinson's disease. Usually patients with Lewy body dementia will have a very much of a fluctuating pattern. One day they'll be pretty normal, the next day they'll be completely off the wall. They get confused, they get lethargic, they have issues with attention, their speech becomes disorganized, and the ability to perform tasks varies greatly from day to day. They often will get visual hallucinations. Visual hallucinations are usually a sign of some kind of organic or physiologic issue. Auditory hallucinations are usually a sign of a primary psychiatric issue. As noted, they have Parkinson's symptoms, the tremor, the gait, those kinds of things, but when you put them on Parkinson meds, especially L-DOPA, they just don't get better. They really don't have any benefit at all from that. So when you have somebody that you think might have dementia, what do? Well, you do the labs to rule out delirium, and then you do the other cognitive testing. It's an interesting question of how aggressive you should be in this diagnosis because, unfortunately, the benefit of the medicines is pretty modest. And so for some patients, the risk of mislabeling someone who does not have dementia as a patient with dementia is probably greater than the risk of late diagnosis. So a lot of folks will delay the diagnosis until they're absolutely sure. You know, it's a really interesting question. If family know, they can plan. On the other hand, it is very challenging for someone to live with a diagnosis that is a chronic, debilitating, probably terminal disease. So when you're doing the history and physical, obviously you're going to get the story of why they're being evaluated, what have been the issues functionally that have brought them to see you. You're going to assess their memory, orientation, language, assess ADLs, instrumental ADLs, and of course executive function as well. Behavior and mood, as always, and do a regular review of all of the medical history and look at their medications and try to find any other possible cause of confusion. People with multi-infarct dementia, aspirin, whether it really has a benefit is not clear. You know, lots of times with people with secondary prevention after they've had a heart attack or a stroke, there does seem to be some documented benefit with aspirin. On the other hand, with primary prevention, it's a lot more controversial. There's a small risk associated with it, but there are people that do get GI bleeds even from 81 milligrams a day. And so it is something that you definitely do with caution. On the other hand, it also has some benefits as well. So, you know, aggressive or at least moderately aggressive hypertension treatment to make sure they're not at extremes of hypertension and keeping their lipids in a reasonable place. I go by the 2013 guidelines, so I really don't treat to a certain goal. But some folks will try to keep their LDL either below 100 or below 70, depending on the guidelines they're following. But obviously that's controversial at this point. So pharmacologic therapy, basically the medicines that are involved are inhibitors of cholinesterase. So they basically block the enzyme that breaks down acetylcholine. So they increase the effectiveness of acetylcholine. So they are cholinergic agents. Now, anticholinergic agents, we use the memory device of can't see, can't spit, can't pee, can't poop. And so if you have unopposed acetylcholine, you're going to have the opposite of that. You know, they'll rarely have vision issues. They may actually have excess saliva. They may produce excess urine, and they may actually have problems with diarrhea. The early medicines that were used for Alzheimer's, the Cognex and that kind of thing, the side effects were actually so severe that they really couldn't be used in the vast majority of patients. The newer medicines have far less side effects. Benefits, however, are still pretty modest. They delay the confusion a little bit, but they don't really prevent it. And once they're withdrawn, the patient goes to where they would have been had they never been on a medicine. So start them at time 0. Patients on a cholinergic agent at 2 years may be where someone who was not on a medicine was at 1 year. However, if you withdraw them at 3 years, they're both exactly in the same place. So you know, there's modest benefit, but I think the the Folstein benefit is a couple of points, which may be enough to maintain their function, but balance the side effects, balance the cost, balance all of that. Now, some of the newer medicines are actually trying to involve other neurotransmitters. Glutamate is the objective for the Namenda and the NMDA receptor antagonists. I think glutamate is going to be for your generation what serotonin was for my generation. When I graduated from nurse practitioner school, there really were no serotonin medicines, and in the 10 years after that, basically all of the serotonin medicines exploded. The antidepressants, the antiemetics, the anti-migraine medicines, all of those basically involve their influence on different types of serotonin. I think that glutamate is going to be something that is much more of interest over the next several years, but as of right now, I don't think it's incredibly well understood. We know that it does play a role in memory and learning, but we also know that in excess it can actually cause nerve death. So we're trying to find ways to maintain the levels of glutamate. Examples that sometimes have been used in the past include ketamine, which is an anesthetic but has some improvement in cognitive function effects with some people. PCP, which of course has changes in cognitive function, although not necessarily desirable. Amantadine is sometimes used post-head injury. It's an older medicine that we used to use for Parkinson's disease. Has some antiviral effect as well, although the benefits of that probably have been eliminated by the specific flu medications, influenza medicines that are available now. Dextromethorphan is an interesting medicine. We use it as a cough suppressant. It does seem to have some benefit as far as protecting brain cells after closed head injury. But again, I think that 10 years from now we'll understand glutamate a lot better. In the meantime, we just have to do the best we can. Something you will hear about at some point probably is Axona. Axona is a clinical food, quote unquote. In one study, it did seem to increase ketones in the brain, which did seem to improve cognitive function. Unfortunately, it was a single study. It does not have to be approved by the FDA in the same way that medicines would, so it is often marketed as a medical food, and it can be quite expensive. It used to be a couple $100s a month. It's probably down under $100 a month. Some families use it just to give themselves some hope. Unfortunately, the benefits seem to be very modest and have not seen great benefits from it. The next I is impaired homeostasis, or also can be conceptualized as homeostenosis. Basically, it's just a decreased reserve. As people age, their ability to respond to challenges decreases. They will have issues with respiratory infection, and where the younger person might be able to fight it off, they don't seem to develop the immune response, and they're a bit more likely to need antibiotics or to need some help. So for me, the threshold for treatment goes down a little ways with the elderly, but that is something that you need to be careful with, because their risk of side effects of medications are at least as high and maybe higher in some cases. So just something to think about and keep it in mind. Urinary incontinence is obviously a common issue. Unfortunately, at least half the women that go see a provider never get any help for their urinary incontinence. A lot of them just assume it has to be managed with pads and that kind of thing. There are a number of different medications. There's surgical approaches. There's physical therapy. There's a whole bunch of different things that can be done. But you have to diagnose it and offer those interventions. So there are questionnaires, but basically you just want to make sure that you ask anyone over 65, or especially people with chronic illnesses, with diabetes. You want to make sure that you ask them, do you leak when you cough? Do you ever lose your urine on the way to the bathroom? Do you use a lot of pads? And so basically just, asking the question and being aware of what potential treatments to offer them. So once you've figured out that they have a urinary incontinence, you basically have to figure out what kind of urinary incontinence they have. The most common type is probably going to be the mixed incontinence, in which they have elements of both urge and stress. There have been arguments as to whether urge and stress, which is more common. Urge incontinence is basically detrusor irritability, and you basically get bladder spasm. That's kind of that gotta go, gotta go. Stress incontinence is, when there's increased pressure on the abdomen, when you're lifting something or when you cough, and it's difficult to hold your urine. So, overflow incontinence is more common in men. This is usually associated with an enlarged prostate gland, and you need to be aware of that possibility. And urologists can easily check for post-void residual. I think at some point we'll have the technology in the office to do that, but most of us at this point don't. Many of you that work in hospitals are actually very familiar with this because you've done bladder checks on patients. Patients with disc issues, B12 deficiency, Parkinson's, other issues also can develop overflow incontinence. Functional incontinence is just basically the inability to get to the bathroom on time. So people with severe arthritis, people with those kinds of issues will have quote-unquote incontinence, but the intervention is to improve their joint pain, to improve their mobility, as opposed to directly affecting their continence status. So the above-the-waist exam is going to be just basically looking for any neurologic or mobility or other issues. The below-the-waist exam is going to be predominantly in women, a genital exam looking for thinning of the vaginal mucosa, looking for what we used to call atrophic vaginitis, which is now mostly called vaginal atrophy. If there's any narrowing of the introitus related to scarring or swelling or other issues, you want to be aware of that. Bimanual exam should be done to evaluate for masses or tenderness. Lots of times you'll have the patient bear down while you're doing that exam, and if there is urine leakage, that is an important sign in regards to stress incontinence. So when you're taking the history for urinary incontinence, obviously if there is sudden onset, it's a bit more likely to be infection or neoplasm. You want to make sure you've done that urinalysis. If there is any blood in the urine, you want to make sure that appropriate evaluation to rule out bladder cancer or kidney cancer are done. If you're looking at other history elements in someone with incontinence, obviously you're looking at sort of a symptom diary. You're asking what their symptoms are, what's the circumstances under which they lose their urine. You want to know what their bowel function is, because of course constipation can be associated with urinary incontinence as well. You're asking if it's affecting them sexually at all, and if there's elements of issues there. Have they had recent surgery? Have they had illnesses? Have they had any previous treatment? So the laboratories, you want to do obviously a urinalysis is a minimum for everyone. Lots of times, rather than just do the dip in the office, you'll send it to the lab for an actual microscopic. Some folks do culture, even if the microscopic doesn't support it, just knowing that the elderly do not mount white count response as well as younger folks. You're going to check their serum calcium, just because if they do have a high serum calcium, they're going to have a polyuria associated with that. Obviously, the differential diagnosis for that can be rather ominous, although sometimes it's as simple as a parathyroid issue. Multiple myeloma is the big issue that you're most concerned about in a situation like that. Check for glucose in the blood to make sure that they don't have any evidence of diabetes. A1C is a great idea if their glucose is elevated at all, but remembering that Medicare and a number of other insurances will not pay for an A1C unless you do have at least one abnormal glucose. You can send them to a specialist to actually do additional stressing of their bladder to see if they do have issues. Post-void residual, sometimes we have to actually do a catheterization to figure that out, and lots of times by then we've sent them to a specialist. Urodynamics have sort of mixed results. A lot of the urologists and some of the urogyne people will do that, then they'll kind of base things on that. Others will just do interventions and see if they can functionally improve the patient. If you've got somebody who has urinary incontinence, when do you send them to a specialist immediately? Well, if they've got obviously abdominal or pelvic pain, that's concerning. If they've got hematuria without a urinary tract infection, immediate is probably within the next 48 to 72 hours. I mean, we're not talking about an emergency, because if it's a true emergency, you've probably just got to send them to the emergency room. But you do want to get these folks in a matter of a few days if you possibly can. If you think they've got a fistula, if they've got any sort of neurologic condition, you might end up sending them to neurology. And again, if you find a mass or any organ prolapse, that's going to be a different situation. Those of you that do a lot of GYN are going to get good at grading cystoceles and rectoceles. The rest of us not so much, but that's going to be an important thing to think about as far as interventions. Surgery can be somewhat helpful in those patients. Unfortunately, the benefit of surgery is not as high as what patients assume it is. So just be very aware of what the actual benefits are of the different interventions. Elective referrals, I mean, basically if you've tried a couple of medicines and you're just not getting anywhere, it's totally reasonable to refer them to urology or urogyne. If you're not sure exactly what's going on, that's fine too. Or obviously if they need something that you can't provide, surgery or pessaries or those kinds of things, it's completely appropriate to refer them. Other treatment, basically you want to just make sure you know which kind of urinary incontinence they have. If they have stress incontinence, then working on sphincter tone can actually be helpful. Medications such as estrogen supplements, especially topical estrogens, can be very helpful in that case. But again, it's not feasible if they're not willing to do that. There's actually some compounded estrogens that we've used in South Berwick with these kinds of folks. Weight loss is often something that will improve urinary incontinence. We used to assume that women that had had babies that had urinary incontinence, it was because of the babies. However, if you control for being overweight, a lot of the effect of having babies kind of goes away. So having babies often causes the issue of post-baby weight. And if you look at women that are nulliparous, that have urinary incontinence based on their weight, it's often similar to parous women. So pelvic muscle exercises, what we used to call Kegel exercises, and many still do. There's definitely some anecdotal evidence for that, although most of the benefit of that seems to go away once you stop doing them. Physical therapy can be helpful. They can do biofeedback. They can do a number of different training kinds of things with patients. And it's worth figuring out whether you have a physical therapist in your area that has some expertise with pelvic issues and especially incontinence. Bladder retraining, basically teaching yourself to become aware of your urges and that kind of thing. Bladder retraining is somewhat different from prompted voiding or scheduled voiding, but scheduled voiding can also sometimes be useful. Bladder irritants such as caffeine, keeping a diary of incontinence can actually help people identify what might be bladder irritants for them. There's a bunch of different medications available for stress or mixed incontinence, some for urge incontinence, and then there's others in research. There's some benefit for them. You'll hear anecdotal evidence. Large studies really haven't shown dramatic improvement in incontinence, but it's definitely worth a try in people. The antimuscarinics have kind of the normal anticholinergic effects that you would expect. There is a new medicine out that is a bladder relaxer that is a beta-3 antagonist, which is less likely to cause those anticholinergic effects. So you do want to be aware of that medication. I may have just misspoke. They're not antagonists. They're beta agonists, beta-3 agonists. And the medicine that is most commonly used is myrbetriq or mirabegron. And it seems to have a fairly good effect. The problem, of course, is that it's still on patent, so it is quite expensive. So something to think about. But if you've got somebody that you really do need to avoid those anticholinergic side effects, that is another option for you. Antimuscarinics, again, they have the anticholinergic side effects. Another medicine that is sometimes used is duloxetine, which is Cymbalta. Cymbalta, of course, is also used for depression. For depression, the maximum dose is maximum recommended dose is 60 milligrams twice a day, but the feeling is that you rarely get any benefit from more than 60 milligrams a day. I do have some patients on the higher dose, and they do think they get more benefit, but it is controversial. Duloxetine for urinary incontinence has shown some benefit with a 40 milligram twice a day. Some nausea, but it usually hasn't been a major issue. When you have somebody present with Cymbalta, that's one of the possible reasons that they may be on it. Chronic pain, depression, anxiety, a whole bunch of different things that it can be used for. Estrogens, as noted, can especially improve stress incontinence with causing the sphincter to close more effectively. And of course, there's a number of different procedures. Pessaries can be very helpful. Botox is sometimes helpful. There's a number of different surgeries that can be done. About 50% of women do have some benefit from surgery. That's way lower than most women assume that the outcomes are going to be. And lots of those women, that benefit will decline over time. So just, look it up, be aware of what the issues are, and make sure they understand their options. The next I is impaired mobility, or also instability. Sometimes when we talk about the Geriatric Giants, some people treat these as two separate ones. Instability we're going to talk about when we talk about falls, so we're not really going to talk about that particularly today. And immobility I'm not going to talk about to any extent, just because that is something that in your undergraduate program you became very aware of the hazards of immobility. And a lot of your basic nursing values and nursing interventions are going to be useful. Time get up and go test is a good way to look at their mobility, but you can, as Yogi Berra used to say, you can observe a lot by just watching. So if you just watch what people are doing, you can often get a pretty good sense of what's going on mobility-wise. The last I is iatrogenesis. Iatrogenesis is unfortunately very common in all of healthcare, and it is quite common in geriatrics. So we want to keep medicines to a minimum. We want to really be convinced that medicines are necessary. Dr. Hallen will talk to a greater extent about polypharmacy later on in the semester, so we won't belabor that here. But I do want to make sure that you are aware that the Institute of Medicine, probably 10 or 15 years ago, came out with a study called Crossing the Quality Chasm. And in that, they estimated that at least 100,000 people a year were killed by iatrogenic interventions. Macquarie et al. Last year in the BMJ actually suggested that that number might be as high as 250,000. He's down at Johns Hopkins, and they did quite an extensive analysis. They suggest that medical error is now the third leading cause of death in the United States. So I think we're going to be progressively more under fire in regards to the interventions that we do and the quality of our care. I think as nurse practitioners, we're maybe a little bit less aggressive than some other professions and more focused on function, and I think we need to continue to do so and continue to be very aware of the potential risks of all of the different interventions that we use. So that's pretty much an intro to the geriatric giants. We're going to continue to talk about them in other talks, but just so that you're aware of the big issues that geriatricians tend to feel that they may have the greatest to offer.